Chapter 14, Psychological Disorders. In this lecture, the basic questions we're going to be addressing are: what is abnormal behavior? What is the medical model? How are psychological disorders diagnosed? What are the most common types of disorders? The past. So some of you are familiar with the Salem witch trials. Took place in 1692. So what really happened in Salem? The story goes, and this is a very cursory summary of the story, was that some young girls began to show very, very odd, or what was at that time considered to be odd behavior. They experienced things crawling on their skin that weren't crawling on their skin. They spoke in tongues. They writhed. They danced naked in the woods, and it got everybody kind of upset. And then accusations were leveled against a particular individual who was a servant in one of the homes of one of the girls, and sure enough, she was accused of witchcraft. And long story short, I believe 16 people lost their lives. One of them a man, most of them women. And they were tried for witchcraft, and they were found guilty, and they were hung. The man died an awful death, being pressed to death by rocks. I guess they pile rocks on a person's chest until they essentially suffocate or they're crushed. So I ask you, in this day and age, do you think that if a group of young girls, or even an individual young woman, began to show signs that they were not okay, that there was something wrong with them, would we explain that in terms of witchcraft or demonic possession? The answer is probably no. But in the past, you've got to remember this is a few hundred years ago, this was entirely possible. So possible that it entered into the court proceedings and ultimately resulted in the death and prosecution and death of a number of individuals. So people were often thought to be possessed and were treated through exorcism should they be exhibiting behaviors that were non-normative, that they fell outside of the range of behaviors that most people accepted as being normal. So why don't we do this anymore? Why don't we consider witchcraft and demonic possession and so forth as being probable causes or even possible causes of a person's so-called abnormal behavior? Well, it's because of advances in medical science. The medical model in particular is a way of viewing abnormal behavior in that it's viewed as a disease. So there's something wrong with a person. It's not witchcraft or spells or demons or anything like that. It's something wrong with them, either biologically or psychologically or some combination of the two. So we're going to look at the medical model and how it approaches what is called abnormal behavior. But to begin, we need to determine what is abnormal behavior before we apply the medical model to it. So you're going to read about Thomas Szasz, Myth of Mental Illness Critique. So Thomas Szasz was an outspoken critic of the use of the medical model to diagnose and treat so-called abnormal behavior because, and this pretty much sums up his argument, how we define abnormal primarily reflects social norms. An example of this was that homosexuality was considered a disorder until 1973. That is, it was included in the big diagnostic manual that we'll look at in a minute called the DSM as a paraphilia. It was a behavior that fell outside of what most people deem normal, or at least the individuals who were responsible for identifying or sorting out what is a clinically diagnosable problem prior to 1973. They determined it was paraphilic. It fell well outside or far enough outside of the realm of normal sexual behavior to be considered pathological. But this went away in 1973. And this is something that we'll discuss in a later lecture, but it brings up the controversy of who decides what's normal and what's not, and what are the implications of that for us. Medical model reinforces labeling and stigma. So this is another reason SAS was objecting to the medical model in application to abnormal behavior. Well, it leads to labeling and the stigma attached to having a label. So for example, many people, in fact, this is the number one reason why people won't seek psychiatric or psychological treatment when they actually could benefit from it, is because they're afraid of being labeled as being disordered, and then they have to carry the weight of the stigma attached to having mental illness or some psychological problems in this country of ours and other countries as well. There's a stigma attached to having some psych disorder. Diagnosis and categorization of mental illnesses can be very subjective, so there's no blood test for depression. That's my example. That is, it's a matter of opinion, and in all cases, diagnosis is a matter of opinion, but in psychological or psychiatric diagnosis, if you're trying to sort out what somebody has by eliminating what they probably don't have, and that is the essence of diagnosis, it is subjective, and it can vary from person to person, and it can change over time. So for these reasons, SAS and others have criticized the application of the medical model in the diagnosis and treatment of psychological disorders. So consider this. Perhaps answering the question of who's normal and who's abnormal is not really what's important. That is, maybe that's not the crux of the issue here, and that's really not the intention of well-meaning providers of mental health care, but rather figuring out if and when somebody needs help is important. And that's the case not only for providers of mental health care, but also for us as individuals with family members and friends who we may observe suffering. When do we determine that that person is suffering to a point where they might need help? That's what's important. And then how do we provide the help that will be most likely to benefit them in the short and the long term? So here we define abnormal behavior. We begin to define abnormal behavior. So Keith was a young kid who would visit us here in New Hampshire, my wife and I, with my nephew. And he was a surfer too, and we'd all go surfing together. And Keith was kind of a funny guy because he'd get seasick when we'd go surfing, so he'd have to take Dramamine. And he was the most lovable kid that you can ever imagine. He was just a nice kid. He was a bright kid, highly motivated. Last July, he committed suicide. He hung himself in the woods. He was going to school at Virginia Tech, and he was struggling with depression. And he had stopped taking his medicine, evidently, and his friends discovered him in the woods. He had hung himself. So clearly this was a shock to everybody, and particularly for his parents, who were devastated, of course. And as a parent, the loss of a child is one of the things that is almost impossible to get past and try to sort out. And you're always left wondering, is there anything that I could have done to prevent this? Did I miss anything? Wasn't I paying attention enough? So then the question becomes, is there anything that I could have done to prevent this? Is there a way that I can make some sort of determination so that I know when that an intervention is absolutely necessary or probably necessary? And then we have other individuals such as Cho and James Holmes. Cho is the Virginia Tech shooter, 32 dead, 23 wounded. James Holmes was the individual that shot up the movie theater last July, or at least July 2012, 12 dead, 58 wounded. Both of these individuals had histories of psychological disturbance. Cho, since he was in junior high school, up until the point, probably 6 weeks, I think, before Cho went on his shooting spree, he was seen in a court of law by a judge who determined that even though he's apparently a danger to himself or others, he shouldn't be locked up as long as the condition is met that he seek help. He did seek help, and so the rest is history. James Holmes, and this came out a few months after the shooting, evidently was considered a dangerous man. A psychologist who he had seen had reported to the campus security, I think it was the University of Denver, that he was a neuroscience graduate student and he had warned the campus security that James Holmes was a danger, but yet there wasn't sufficient intervention to prevent what ultimately happened, which is him shooting up the movie theater. So these are extreme cases, the case of Keith and these two individuals that beg the question, when is a behavior abnormal enough such that we are compelled to make an intervention before somebody commits suicide or before they go on a shooting spree? How do we make that determination? Of course, these are extreme examples. Somebody doesn't have to be at these extreme points of killing others or themselves in order to need help, but this is an important question for us. So in determining whether a behavior is abnormal, clinicians rely on the following criteria, and perhaps we could too, as lay people. Is it deviant? Does it violate societal norms? And this isn't just dyeing your hair blue, right? This is behavior that goes so far beyond what society deems acceptable that it is deviant. It is considered deviant. Is it maladaptive? That is, does it impair a person's everyday behavior? Can a person get up and go to work every day, or do they have to sleep until 3 o'clock in the afternoon? Are they able to pay their bills and so forth? Some deviant behavior is so deviant it becomes maladaptive. Not all deviant behavior is maladaptive, but often deviant behavior can become maladaptive. That is, if you insist on going outside and going to class without any clothes on every single day because you think your clothes are infected by aliens, then certainly that's deviant behavior that is maladaptive. 3, does it cause them personal distress? Does the person seem to be suffering in any way? So any one of these or some combination of the 3 we need to consider and then make a determination. And if it's the case that somebody is suffering, for example, to the extent that it's affecting their ability to get along in the world, then we need to consider diagnosis and treatment. So even though Thomas Szasz suggests that the medical model is misapplied in cases of abnormal behavior, because what abnormal is simply is those behaviors that violate social norms, that's one certainly an important consideration, but there are definitely cases where people are suffering, their behavior is maladaptive such that they can't work and their relationships are deteriorating and so forth, that we have to make a move. The person obviously needs help and could possibly benefit from help. So here's where the medical model comes in. In the medical model, as we learned a couple minutes ago, abnormal behavior is viewed as a disease. The components of the medical model include diagnosis, etiology, prognosis, and prevalence. My hunch is that you're familiar with some of these terms or these components, what they are, but we're going to go through each one of them and we're going to look at them one by one, starting with diagnosis. So diagnosis involves distinguishing one illness from another. So it's a process of elimination. Somebody reports to the consulting room complaining of symptoms that are affecting their ability to get along in the world and so forth. And so we begin to try to sort out what is the problem that they're suffering from by determining what it is likely not to be. And here's where the big book, the DSM, enters into the picture, the Diagnostic and Statistical Manual of the American Psychiatric Association. So I have the covers of the last 3 editions. So we're currently in the DSM-5. This just came out in 2013. Prior to 2013, the DSM-4-TR and the DSM-4 were being used. And I believe it's the DSM-4 or the TR that is covered in the text, the latest edition of the text for this course. But all apply. There's minor changes from one edition to the other. But you can think of this book as the big book that is used pretty much worldwide in order to diagnose psychological or psychiatric disorders. We're going to look at the characteristics of the DSM. So it's a multi-axial system with 5 axes. So on axis 1 are the clinical syndromes. So this axis 1 lists all the symptoms of the particular problem. So you have symptoms of depression and schizophrenia and so forth, and all the different disorders that are in the DSM. And so you would be able to identify or match a person's reported symptoms with the symptoms that you see on axis 1, and then in part make a preliminary determination of what they're suffering from. Axis 2, personality disorder or mental retardation. So when we're considering what a person is suffering from, we have to be able to rule out or rule in personality issues or mental retardation, some sort of cognitive impairment. So I have, is he or she a depressive type? So I'll give you an example. When I worked in mental health, and I did so as a case manager for a few years, there was an individual, a woman, who was constantly depressed. Intractable depression actually, wasn't responsive to any sort of antidepressant or therapy, seemingly untreatable. It was determined that she was a depressive type. That is, it was a personality disorder. It was trait level. So there was really not a whole lot other than behavior therapy that could be done for her. So you want to be able to, for example, rule out whether it's the problem is at a trait level, it's something about their personality, or maybe it's something that's due to possibly, in this case, depression, maybe bereavement, maybe they've lost a loved one, and so naturally they're depressed. Maybe it's some dysfunction at the level of neurotransmitters. There's some organic basis to it. So that's axis 2. You want to rule out or rule in personality disorders or some other issue, some other cognitive issue. Axis 3, general medical conditions. So did they just have heart surgery? So again, with the depression, it's typical that people will be depressed after major surgical procedures. So you want to be able to capture their medical history, current and past. Psychosocial and environmental problems. So usually you get a good background on the individual, very specific questions, and so you can get a sense of what their developmental history included in terms of trauma or any other issues or events that might have contributed to their current status. Environmental issues that they're having. Are they struggling with poverty? Did somebody just die? Are they bereaved? Other stressors that might be underpinning their current issues. And then axis 5 is the global assessment of functioning. So we're going to take a look at this. So this is the GAF scale, and essentially you can score anywhere between 0 and 100. So 100 is high functioning, 0 is inadequate information, and then between 1 and 10 you're a persistent danger to yourself or others. So if you score somewhere between 1 and 10, you can be voluntarily or involuntarily committed for observation to a locked psychiatric unit. And this was the case, and chose the Virginia Tech shooters. That the judge could have locked them up, but she didn't. So that's the DSM diagnosis. Now we get to etiology. That's the cause of the illness. So the cause of the illness is considered to fall within the biopsychosocial model. That is, usually the cause of illness includes a interaction of biological factors, that is genes, neurotransmitters, psychological factors, stress, and emotional trauma. So as you read about the psych disorders and their etiology, you'll notice that stress is one of the precipitating factors to every single one of them. social factors, poverty, conflict, lack of support. So this is what's called the biopsychosocial model of mental illness. So when we're considering the cause of illness, we consider all these factors. Prognosis is a forecast about the probable course of the illness. So if an individual is diagnosed, then they're going to be interested in knowing what they can expect in the short and the long term, and that's prognosis. Prevalence, percentage of people that exhibit the disorder. So it's important to have statistics, and these are gathered using large epidemiological studies. Usually you grab a very, very large random sample, and then you discover the fraction of the sample that are suffering from one or the other of the conditions, and then that becomes your prevalence statistic. And it's important to have some sort of idea of what fraction of the adult or child population suffers from particular disorders, because that helps in diagnosis. So if you know that a disorder is occurring in 1% of the people, then that's an unlikely diagnosis. So that wouldn't be your default diagnosis. If it's a very rare disorder, you probably wouldn't default to that disorder in trying to explain somebody's symptomology. So it's important to have an idea. And it's also important to have percentages of sufferers for other reasons. So concept check here for you for these terms pertaining to the medical model: diagnosis, prevalence, etiology, and prognosis. So what I'd like you to do is just pause this really quickly and pull out of this case study that information that pertains to diagnosis, prevalence, etiology, and prognosis. So pause this and see if you can identify the information that pertains to those components of the medical model. All right, so assuming you're back, we'll start with diagnosis. So that section in red is the information that pertains to diagnosis. Dr. Bruce locates a symptom on axis 1 of the DSM. That's where the symptoms are of the disorder, and determines that Stanley is most likely suffering from major depression as opposed to some other psychological problem. How about prevalence? Here are the statistics. He's confident in his decision because he knows depression is relatively common, around 13 to 16% of the population. Etiology. Stanley is also informed that he's in the middle of an ugly divorce and that both his father and mother suffered from depression. And Dr. Bruce knows that depression is a genetic component and can be precipitated by stress. Prognosis. He prescribes an antidepressant and recommends Stanley seek psychotherapy. He tells Stanley that he can expect to begin to feel better within 2 to 3 weeks. He also tells Stanley that in some cases depression can become chronic, which means he may need to continue on his medication indefinitely. All right, so what I'd like you to do is this. I've attached a link, or I've included a link in to the Discovery Psychology video on the psych disorders. What I'd like you to do is watch the video with a view to identifying 3 things. So identify the 3 major types of disorders, identify their symptoms, and etiology to the best of your ability. And this is just to get you ready for the next lecture on psychological disorders, where I'm going to ask you to do a little diagnosing and recommending. So watch the Discovering Psychology video featuring Philip Zimbardo. It's about 30 minutes, and then watch lecture 2. So here's what we did. Here's the learning objectives for this section. Describe the characteristics of the medical model, describe the DSM diagnostic system, describe axis 1 through axis 5, identify the criteria used to define abnormal behavior, and explain Thomas Szasz' notion of the myth of mental illness.